Surgical integrity. Surgical integrity. Module 5, surgical integrity. Objectives. By this end of this module, you should be able to describe the phases of the operative plan, apply the nursing process to develop a clear plan for a patient undergoing an operative procedure, evaluate the intraoperative complications and interventions for management of care, describe the ethical conditions within the intraoperative, and then identify patient safety concerns within the intraoperative setting. The next few pages are some key terms that you should have a knowledge about. Here's categories of surgical procedures. You have your major surgery, which is greater than minimal risk to life. It involves more than one multiple system, or it requires long periods of time in the operating suite. I know some can attest to that work in the surgery suites. I know there were some surgeries that we would have that we would involve plastics, ortho, and neuro, and the patient would be on the bed 12 to 14 hours. So that would have been considered major, where minor is minimal risk to life, usually one body system. And there's a minimal incision length and depth. So you're talking your appendicitis, having your appendix removed. It could be having tonsils removed. Elective surgery, this is surgery that is subject to choice. It's not life-threatening, and you can live without having the actual surgery done. There are 3 types of elective surgeries. There's required, selective, and optional. Required is like corrective, so your cataracts, bone deformities, or joint replacement. It could be tonsils. Selective, there's no real threat to immediate physical health, and it can help improve comfort or emotional health. So that could be like your ovarian cysts, cleft lip or palate, hysterectomies. Most of them are. We do know that if somebody was hemorrhaging and needed to have a hysterectomy, that would not be considered selective. And your optional, which is primarily the cosmetic benefit, so your wart removal, your cesareans on demand, your breast implantations, liposuction, all those types. Non-elective surgery is urgent and emergent. Usually it's due to trauma, so like a motor vehicle accident or a shooting. And it has physiological urgency, which is saying it's life or death, or it could be in a disaster that's happened. Urgent means it's quick, but doesn't have to be immediate, but the surgery is required within 24 hours. Emergency surgery is when delaying treatment would significantly increase the threat to the patient's life or their body part. Severe pain due to broken bones, could be uritic stone, giving birth. They're not considered emergencies. So we know more motor vehicle accidents there. Bleeding out or body part motor vehicle accident. They've lost their leg. They have the leg and they need to reanastomose it to get it to try and get the limb functioning again. So just stones, giving birth, broken bones aren't emergency. Giving birth would be an emergency if it was the risk of mom and baby dying. In emergency surgery, patients are often hypovolemic and they require aggressive care post-op or preoperatively and intraoperatively. and usually it's more complex for an entire operative team. We've seen this when patients would come down with a AAA, and it was life or death, and you had to work together as huge teams to get everything ready for the doctor to open up the chest and work on saving the patient's life. There are different phases of the operative. There's preoperative, intraoperative, and postoperative. Perioperative nurses provide care during all three phases. And most perioperative nurses have training for 6 months to a year, so they can learn everything in the operating room, the preoperative part, the postoperative part. Preoperative begins with the decision to have surgery, and as soon as when the patient is transferred to the operative table, it becomes another phase. Physical and psychological preparation for surgery begins in the preoperative phase. Intraoperative, as soon as the patient's transferred to the operative table, it is considered intraoperative. It ends when they transfer them to the PACU or the patient care unit, anesthesia care unit. In the intraoperative, we're watching for patient safety, facilitation of procedure, preventing of infections, good physiological response to procedure, and anesthesia. The postoperative begins once they're transferred to the PACU. It ends with resolution of surgical sequelae. Much of this phase takes place at the home, support of physiological systems. Later phase, you need to reinforce information for care at home. When you are doing surgery, there needs to be a surgical consent form. The physician or the surgeon is the one that does this. It entails the surgical procedure, describing what the procedure entails, the anticipated risks of having or not having the procedure, and then any alternatives to the procedure. Also during this time, the nurse will give patient the education, and they'll witness patient signing the consent form. Patient intake procedures, name ban, they'll have an allergy ban. If there's an advance directive, we want to make sure that one's on there. If they're NPO status, well, most often they have to be NPO, especially if they're going to be putting under. You also need to remove personal items like clothing, jewelry, dentures, glasses, hearing aids. Most of the time, they'll give them a gown, but most of the time they've showered before they came there. Preoperative nursing usually is where IV placement's done. They'll make sure that they voided any blood work that needs to still be done, educating them on what the expectation is during surgery, post-surgery, any skin preparation that needs to be done, and then at that point usually they will put TEDs on. Planning and implementation, age-related considerations. Children, what size they are, developmental stage. A huge thing with the younger, the toddler areas, is their separation anxiety. And that's one thing with surgery we need to make sure we are looking for. Most often what will happen is that they'll have the patient or the parents actually go into the surgical suite with them, and they tell the patient's gone off to sleep, just because it makes the patient more comfortable, the child, it makes the parent more comfortable, because in that toddler, the biggest thing is the separation anxiety. For the older adult, they have the comorbidities, and then they also have decreased adipose, so they're at bigger risk for skin breakdown. So with the elderly especially, we want to make sure that they are padded really well, especially on any pressure points, just because most often they do not have the extra padding that the rest of us have. And sometimes just when they get older, their skin starts to thin, which puts them more at risk for skin breakdown. And sorry, I'm really stuffed up, so I'm hoping this isn't making a difference. Planning for patient safety, we want pharmacology, so giving them preoperative medications. We want to make sure that when they do get those preoperative medications, that they, especially if it's an anesthetic, we don't want them up and walking around without having a cyst, because it puts them at a risk for falls. For allergies, we want to make sure that we aren't giving them anything that they're allergic to. And if they do get something that they find out later that they're allergic to, what we want to assess first is just make sure they're breathing, not having anything like that. Don't jump to giving them an EpiPen right away, especially if they're able to communicate to you that they think they're having an allergic reaction. Huge thing, want to identify the correct surgical site. There has been a lot of times, probably not so much now as it was in the past, where actual wrong organ was removed or wrong leg was amputated. So we just need to make sure that the correct site is identified. Transfer strategies depending on their weight, their mobility, and then also make sure family is aware and that you are updated on what family is there and make sure they're educated. Environmental safety. There could be anesthetic gases and sparks. We want them in normothermia, and then just watching out for sharps, so the needles are most often what is seen in surgery, or the knife blades. Preoperative medications, you'll see opioids given, amnesic muscle relaxants, anticholinergics, and antacids a lot of times are given. The role of the perioperative nurse, they have specialized knowledge base in physical skills. They practice principles of asepsis, sterilization, disinfection, and infection prevention. And this is where I was talking about the perioperative nurses most often go through a training, which is usually up to a year before they're actually let out on their own. Surgical team usually is the surgeon, anesthesiologist, the CRNA or the nurse anesthetist, the operating room nurse. Usually they could be a scrub nurse, they could be a circulator. Some facilities have registered nurse first assistants, where in some clinicals those RNFAs are actually residents. It's a teaching hospital. They'll have education coordinators. Usually there's a director of surgical services of the operating room, and then you'll have surgical technicians. Anticipated outcomes of nursing. Nursing sensitive outcomes or indicators. They use perioperative nursing data set. They use this to measure and compare outcomes sensitive to a nursing care, so they use 3 data points. Patient problems, nursing interventions, and outcome achievement. Examples of intraoperative interventions you can look on box 24 or 21-4. For bariatric considerations, you need to make sure that you have the right size of equipment, cardiorespiratory status, watch their airway, core morbidities. A lot of times they're hypertensive and have diabetes. Surgical environment is asepsis and sterility, traffic control, so you don't want people just walking in and out and in and out. They try that if you are going into an OR room, it should be because you're needed in there or it's the room you're in. So it's not like walking down the hall. You shouldn't be using an operating room for a cut-through. methods of sterilization, sterilization of supplies and equipment, and then constant monitoring to make sure that sterility is not broken. Surgical asepsis, general infection control practices. You could have personal protective equipment. There's surgical hand washing that we talked about that you do. And then the surgical team wears sterile gowns and gloves, and everything is done sterile technique. They have, for patient safety, they do have timeout or pause for the cause. Sometimes this is right before surgery starts, and they're just making sure we're doing the correct site, we're doing correct patient. So it's kind of just the figuring out and making sure everybody's on the same boat. Watch out for lasers, the reflective and low reflective instruments, anytime there's a fire or an explosion. Following all operating protocols, surgical fire, latex, or if the patient goes into cardiac arrest. Patient safety, also looking at wrong site surgery, what are the contributing factors and risk reduction strategies so it doesn't happen again. And then also their transportation, making sure that when we're transporting them from the operating room to the PACU, rail leads are up, that the patient is somewhat cognitive, and if not, they are secure so that there's no fear of them falling off the cart. Anesthesia and sedation. For sedation, you have minimal and you have deep. Deep sedation, they are going to be really snowed, but still not have to have an airway, and then we have their minimal sedation. Types of anesthesia, we know that there's local, so just the area. They can have a regional, where it's an epidural, spinal, nerve, or a nerve block. And then general, we know they are completely put under and are not breathing on their own. They're intubated. And here goes into sedation as to whether it's minimal, moderate, deep, or general. So you can look at these different ones. Risk of anesthesia could have an adverse reaction to anesthetic. Huge thing we don't want to happen is malignant hyperthermia. In this, you'll see that their temps spike, and they'll give dantrolene for this. So you want to make sure that you act quick. People can get nauseous, vomited, sore, dry throat from the tube down their throat. Can have damage to the vocal cords because of the tube, or numbness or loss of function, usually in a regional anesthesia. Sometimes this is just temporary, and sometimes this can happen and it is permanent. Intraoperative complications could be retained objects. That's why they always make sure they do surgical counts, especially with lap sponges. Unrecognized tissue damage, so accidentally nick an artery or a bowel. Hypothermia, the consequences to that, managing patients' temp, giving them intraoperative fluid management, and then safety and positioning, so we just need to make sure that they're padded really well. Talking about malignant hyperthermia, there's manifestations on 535. They could have masseter spasm, metabolic acidosis, elevated creatinines, arrhythmias, tachycardia, hypoxia, hypovolemia, and high fever. Management crisis is box 21-9, and prevention. Look at that. But management crisis, we're giving them dantrolene. PACU, or Post Anesthesia Care Unit, was developed after World War II. They kind of keep them in the PACU to watch for possible post-op complications, function and setup, recovery factors. They kind of watch them coming out of anesthesia, make sure that they are physiologically stabilized, make sure the wound's stabilized, and kind of getting their pain under control before they either let them go or home or send up to the floor. Most often people are in the PACU for usually 1 to 2 hours, and then they'll either go home or they'll send them up to the floor, but they do assess for readiness, and then this Aldrich scoring, which is on the next slide. Discharge usually from the PACUs usually after 1 to 2 hours. They need to assess their readiness as to whether they're ready to go to the floor or ready to go home. The responsibilities of the PACU is to report to the receiving unit, make sure they're transferred to the appropriate unit, and make sure the transfer is safe. Possible post-op complications could be respiratory, cardiovascular, thermoregulation, neurologic, GI, GU, integrity or integumentary or musculoskeletal. Nursing care during the first 24 hours. Short stay patient usually is because the insurance is only going to pay for a day or two, getting their pain under control, and then making sure that patient educated and family, and then discharge teaching, patient receiving inpatient care. We want to make sure that the receiving nurses had gotten all of the information and they know exactly what type of care needs to be given, and then communicating with family. Care beyond the transfer, we want to have close observation, rapid response team, make sure there's always safety, prioritization, make sure they're getting the nutrition and fluids they need. If they're on a PCA pump or just plain pain management, we're keeping that controlled, and continual wound care assessment and care for that wound. We also want to be making sure that they're using the anti-embolism devices, so like the TEDs or the SCDs, documentation like we should, giving them their meds, remembering ABCs, making sure that they're using their incentive spirometer, and then anticipating any type of complications. Discharge planning for home involves multidisciplinary, which would be the surgical doctor, the nurse educating, could be a wound nurse, depending on what type of surgery. It also could be a dietitian. Teaching learning principles, we want to make sure the patient and family are knowledgeable on what they need to do and that they show that they're ready to learn. Once they get home, they'll usually have a follow-up call from the nurse. Family and friends visiting could potentially have home care nursing depending on what their surgery was for, and then any evidence-based practice guidelines that need to be followed. While they're home, we could have a delayed recovery. We could end up with an infection. Delayed resumption of GI functions, which is one of the reasons why they are hoping that they are either having gas or a bowel movement before they leave, but some of the problem is they ship them in and ship them out because of insurance, that sometimes that function isn't back yet. Also want to predict and prevent outlier situations. Sometimes they will need long-term recovery in special settings, especially for ones that need to rehab. Lastly, patient and family education. You want to get them pre-printed forms, verbal review, and return demonstrations. Make sure they're updated on the wound care. Make sure they know they need to, what type of activity they should be doing and resting. Updated on the medications. Always inform them of possible complications. Give them electronic resources, websites, internet-based post-op teaching and support systems. Remote monitoring. They may have online resource identification. These are all things. So the care, as they talked about, it's all perioperative, from pre-op to inter-op to post-op, which we talked about. Post-op can be also all the way to them actually being at home.